Hello, everybody. My name is Tommaso. I'm a consultant radiology working in the University Hospital of Messina, and I'm going to talk about the COVID-19 related cardiovascular effect and on the role of imaging in the diagnosis, the prognosis, and the long-term follow-up. As a first overview of COVID-19, we know that it's a pandemic that has caused over 251 million confirmed cases all around the world with 5 million deaths. And it's basically caused by a coronavirus, SARS-CoV-2, which thanks to its S protein, spike protein, attached to human cell receptor in the upper and lower airways, causing the infection. Usually the incubation period is thought to extend up to 14 days, and 97% of the people develop symptoms within 11 days. However, about 1/3 of the population may not present any symptoms, despite may show some radiological sign of pneumonia at radiological tests like CT. For those who will present symptoms, the clinical course can be variable, with mild to moderate course for around 80% of people who present only mild symptoms like cold and cough and sore throat. However, it can turn to be this severe in 14% of people who will manifest dyspnea and hypoxia, and it can be critical in 5% of the patients with the respiratory failure, shock, multi-organ dysfunction. In this cohort of patients, about 1 out of 2 can have a fatal course. The diagnosis of COVID is made by swab PCR test, so that it allows the detection of SARS-CoV-2 viral RNA in nasopharynx samples, and it allows for the diagnosis of the infection. However, chest CT, since the beginning of the pandemic, has been considered as a primary tool for the detection, even in epidemic areas. And since it can show pneumonia signs in even more than 50% of patients without any symptoms. Typically, the lesions of COVID-19 are ground glass opacities, as shown by the red arrowheads here on the images. And as we see in this example, chest CT show a good sensitivity for the diagnosis, since we can see on time point A and time point B a substantial agreement in terms of number of lesions and aspect of lesions. But however, we can see on the right that on time point A, the patient tested negative at the PCR test, while it was positive on time point B. So the exam of chest CT has a good sensitivity. However, the specificity is not as good as PCR test, or at least that's how it happened in this case, in which a patient with 37-year-old man presented to emergency department with cough and fever, and the chest CT appeared to be negative, with a PCR test which is positive. However, our research topic was to improve the diagnostic performance of chest CT by adding the minute reconstruction. In this case, we saw that adding the reconstruction of minimum intensity projection, a lesion that was really subtle, was not visible on the conventional chest CT, appeared to be present and allowed to increase the specificity of our examination. We saw that the use of minute reconstruction improved the visualization of COVID-19 pulmonary lesions compared to standard images in a multi-center retrospective analysis of over 180 patients. However, what about the prognosis? Can the imaging give information about the prognosis? Usually, you know that laboratory tests like lymphopenia, neutrophilia, elevated serum, ALT, AST, and LDH, or high C-reactive protein and high ferritin levels, are all associated with greater illness severity. But can you extract information about the prognosis of a patient from a chest CT examination? That's what we try to do, adding an artificial intelligence algorithm to our images that allowed us to quantify and score the severity of COVID-19 lesions with excellent reproducibility. So in this study, we saw that artificial intelligence allowed to correlate with laboratory and clinical data, and to serve as a predictive marker of the clinical course, thanks to the excellent reproducibility and to the possibility to serve as a score. But let's go now on the cardiovascular side. We know that COVID-19 can give also cardiac involvement as a complication, is a complication of COVID-19, but can manifest also without any symptoms or sign of interstitial pneumonia. As in this case, in which the chest X-ray, chest plain film was negative, but the cardiac MRI showed diffuse cardiac involvement with signs of myocarditis. Usually, these signs manifest with increasing native T1, T2 mapping values, with impaired left ventricular ejection fraction and longitudinal strain, with pericardial enhancement and/or effusion, with late gadolinium enhancement with patchy, linear, or mid and subepicardic pattern, and with signs of stress-induced cardiomyopathy. What's the pathogenesis of the myocardial involvement in COVID-19? It's still unclear. However, the main hypotheses are the direct myocardial infection by the virus or the increased cardiometabolic demand associated with the systemic infection. What happens, in fact, in the severe cases is that elevation of pro-inflammatory cytokines can cause a systemic inflammation, a catecholamine surge, and can lead to coronary thrombosis and cause also acute coronary syndrome. Naturally, these effects are more severe in people who have underlying comorbidities like hypertension, cerebral mellitus, and coronary artery disease. In the autopsy specimens, so far, macrophage infiltration has been the main finding, showing that rather than a direct damage of the virus, the cardiac involvement is more a result of elevated systemic level of pro-inflammatory cytokines. However, cardiac injury is a common condition among patients who are hospitalized and who need intensive care unit admissions, and it's associated with higher risk of mortality. So for this reason, what we wanted to do and what we are aiming to do in our research topic is to combine the artificial intelligence algorithm and the calcium score in a comprehensive assessment of our patients in order to give a combined score to offer a great potential score that can preventively identify individuals at high risk of prolonged hospitalization and ICU admission. But now let's come to the follow-up and the role of imaging in follow-up, especially for cardiac involvement. So we know from recent literature that for people who are asymptomatic or have only mild symptoms of COVID, cardiac MRI after 6 months show no cardiac involvement. Basically, we have similar findings in people who had a mild course of the disease compared to the seronegative healthy volunteers. On the other hand, for those who had a moderate, severe, or critical COVID course, the cardiac involvement was present at the follow-up MRI, and in 60% of them, there was even ongoing myocardial inflammation, which basically manifested with higher native T1 and T2 values. So our future research topics aim to further investigate the long-term cardiovascular consequences of COVID-19 in order to prevent the onset of cardiovascular complications that can be like chronic myocardial inflammation, dilated cardiomyopathy, the development of arrhythmias, and coronary artery disease, and all conditions that can lead people to sudden cardiac death. With this, I thank you for your attention.